Welcome to week 6, cost-benefit analysis. This week we'll be reviewing chapters 8, 15, 17, and 19. Chapter 8. The shift from hospital to home care became possible through advances in technology. Home care has become practical as more and more operations and treatments previously offered only in hospitals were provided on an outpatient basis. Dialysis, intravenous antibiotic therapy, blood transfusions, chemotherapy, and ventilator and pain management programs can all be safely administered in the home setting. In some cases, cost savings can be significant. Home care is particularly appropriate in certain types of cases. Long-term chronically ill patients with chronic neurological problems such as multiple sclerosis, those recovering from a complex traumatic brain injury, cancer patients, AIDS patients, and those affected by either hemophilia or genetic emphysema. Home care is felt to be a healthier, more humane alternative for the critically and terminally ill. Proved to be effective for most, but no means all recuperating patients, the home care process keeps each patient in the hospital only as long as coordinated medical team approach is required, and then explores all avenues of removing the patient from the hospital while still providing the quality and comprehensive services needed. When an individual is hospitalized, it can be a very disruptive experience for the entire family. Consequently, consumers have welcomed care alternatives, especially home care, which for many is the most attractive option. There is some uneasiness among consumers about home care. All patients may not welcome it. The hospital environment provides a sense of security. Facing the loss of their safety net, patients and their families need to be convinced of the benefits and safety of home care through education and the correction of misconceptions. A case manager must approach each case considered for home care very thoroughly and be the link among the physicians, the discharge plan, the patient, the family, at-home service providers, and the payer. The case manager concerns lie with medical, nursing, and benefit payment issues dovetail. A home discharge must be safe. Although the primary care physician, in cooperation with any other consulting physicians, has responsibility for discharging a patient, all those involved in the patient's treatment plan, including the nursing staff, the case manager, and home care company employees, share in the responsibility and liability for providing appropriate care. Most benefit policies and discharge plans automatically mention RNs as the most appropriate care support, even when other services from within the home care spectrum might provide more effective help. A home health aide, homemaker, or personal care assistant might tend to the patient's needs very well. Instead of assuming that a benefit plan or discharge plan is etched in stone, case managers need to argue for a solution not covered by the plan language to create a better answer. Case managers need to be accurately aware of the vulnerabilities of patients as they bring patients home. Another consideration is the geographic setting of the home to which the patient will be discharged. Is it a rural area, suburban neighborhood, or inner city area? A personal visit to the home illuminates conditions that may affect the safety of the discharge. The family may have failed to mention that the home is an apartment 5 flights up with no elevator and is so small that there is no room for oxygen equipment. A case manager must approach each situation individually, evaluating the patient's conditions and ongoing needs in consultation with the physician, the family member who will main care provider, the availability of respite for the care provider, and a range of community services. After the various elements of home care are successfully established, the necessary medical equipment delivered and set up, the nursing hours arranged, and supplies ordered. Sometimes the case manager may need to bring in additional support services so as not to overburden the caregiver. The case manager should actively pursue and receive feedback from all sources, the healthcare providers, the durable medical equipment, and so on. This regular feedback allows the case manager to follow the patient's conditions and evaluate the need for services. It is unfortunate when a case manager learns from a payer that a patient discharged at home 2 months earlier had been back in the hospital for a week because of deterioration in his or her condition or the failure of the home care setup to function as planned. When turning a case over to a payer in-house case management service, the case manager should relay all pertinent case information and acknowledge the ability of the payer's case management to take the case, but also make it clear that she is available for interim on-site assessments as needed. She should also suggest that the claims examiner call her if certain complications arrive and leave a list of red flags for his or her reference. Decisions should not be made arbitrarily by one of the parties. Ideally, the case manager should be the one to adjust the level of services and then discuss all the ramifications of any changes with the providers, services, and payer. The case manager must make it clear to the family that if there is a problem with equipment, if they are not satisfied with the healthcare provider, or if they are overwhelmed, they should call the case manager. In most cases, home care is less expensive than hospital care. However, cost savings are not automatic. Expenses must be calculated, managed, and negotiated. The case manager must determine if and to what extent a benefit plan will allow home care. In allowing alternative arrangements, employers and benefit administrations often talk out of contract benefits or contract exceptions. That is, benefits they are not required to provide. Employees need to learn, and case managers should be prepared to do the informing, that alternative arrangements should be viewed as something done to prevent greater contract exposure. In addition to investigating and pursuing all the benefits obtainable through the patient's health plan, the case manager should utilize other resources for providing at-home services to help the patient and payer defray costs. There may be local, county, and state agencies and disease-specific organizations, foundations, and philanthropic groups that can provide services or guidance. The case manager must hone negotiating skills in order to deal with home care providers effectively. The case manager need not accept the usual per diem rate, but should suggest an appropriate rate. Assuming services are satisfactory, the provider can look forward to a guaranteed income from a specific duration. The Affordable Care Act, also known as the ACA, has created several tools that allow you to compare a variety of quality measures of healthcare and services provided. In addition, the Partnership for Patients program highlights hospital and other providers that have made a commitment to reducing medical error, improving healthcare quality, and reducing costs. A long-term case is diagnosis-driven. Long-term care is typically needed for patients with multiple sclerosis, cerebral palsy, cancer, brain or spinal cord injury, or multiple trauma. Services may be required for several months, years, for life. To recognize a long-term care case, a case manager refers to the diagnosis, all available medical data, and the prognosis. Following are 5 red flags indicating potential long-term care cases: lack of improvement or compliance, terminal illness, 6 months of treatment, multiple medical conditions, and an increase in complications indicating possible systematic involvement. Long-term care cases, those that require 6 or more months of case management intervention, are to some clients and payers. A client's perception of a patient's probability needs more difference substantiated from the case managers. Therefore, it is very important to clarify the role of the case management in long-term cases to the client. Some case managers, especially those with less experience or those working with a new client or referral source, are reluctant to be totally honest. In an effort to maintain the client relationship, they knowingly overestimate anticipated progress in long-term care cases or withhold especially stark information. For a case manager, the type and level of involvement on a long-term case depends on several factors: diagnosis, patient age, prior medical history, current medical situation, treatment plan, services required, timing of his or her introduction to the case, and the amount of family support, among others. After the case manager has put the treatment plan into action, the goal of case management is to enable the people most directly involved with long-term illness, the patient and family, to live as comfortably and normally as possible. In long-term care cases, ongoing involvement is always advisable. It does not only benefit the patient and family, but also the client, providing increased cost containment because problems are addressed early. Continuing contact can be achieved in several ways, depending on the client group, its in-house capabilities, the funds available, and other factors. Ongoing contact helps pick up on potential trouble spots, improves the patient-physician-family relationship, maintains a liaison with the services providers, manage caregiver burnout, and provides perspectives to improve or setbacks in patients' conditions. Challenges in long-term cases include long stretches of slower, less evident progress and plateaus. When negotiating for long-term services, case managers often overlook a cost containment tactic available to them. Long-term care cases provide a long-term guarantee income for services provided. Intense negotiation is particularly appropriate when a patient needs and the required levels of services change during a prolonged period of time. An individual brain injury or multiple trauma patient may demand intense skilled nursing and ancillary services at the outset of treatment, but will require less and less care during the later stages of recovery. Financial resources for long-term care are always a concern. Long-term care insurance policies vary greatly in the type and extent of funding they provide and the restrictions, but on types of services. Case management can also be applied to manage the long-term care of older adults who are not seriously ill but require support services. Gaining in popularity, geriatric networks or continuum mirror the best case management programs in that they move the elderly population away from fragmented episodic care into an integrated model that is flexible and offers a range of services designed to meet the needs of the population. Just as the patient should be encouraged to find a disease-specific support group, so should the caregiver be encouraged to arrange for periods of respite and to talk to people facing similar challenges. Quite often in long-term care cases, strains that existed in the family before the illness become exacerbated, and the whole situation seems beyond remedy. It is important to note that long-term care cases have many implications, often hidden at first, for case managers. Case managers react very differently when working on long-term care cases than on shorter cases that frequently have positive outcomes. When no longer objectives are effective and no longer a catalyst for improvement, case managers need to be owning concerning their own feelings. Insurance companies, reinsurance companies, self-insured firms, and self-insured, self-administered corporations vary in their benefit structure and how they work with case managers. Therefore, it is important for case managers to understand each of their operations. The role of the case manager becomes more complex the larger the company is that is insuring and the larger the group that is being insured. Size and type of both the insurer and the insurance administrative arm will impact the autonomy of the case manager's role, influence the format and frequency of communications, and affect the case manager's ability to obtain approval for allowances or exceptions in coverage should the need arise. Because the activities of case managers are largely mandated by both federal and state regulations, it is the case manager's responsibility to know the effect of state regulations on different health insurance benefits. In the majority of cases, some case managers will be employed by the payers, which is the insurers, and their work will be governed by the group, department, and agency carrying the fiduciary responsibility of the benefit plan. The traditional insurer-client relationship, a company or individual pays an annual premium to insurance firm. The cost of any particular benefit plan is determined by the breadth and the length of coverage that will be provided. In response to rising insurance costs, many businesses have a pursuit of alternative financial methods, such as self-insurance. The switch to self-funding results in a significant initial reduction in healthcare benefit costs for individual companies. In self-funding, companies assume dollar-for-dollar responsibility for employee health care and avoid the spillover of financial responsibility previously included in their premiums to cover other clients or insurer might be carrying. With the appearance of self-funded plans, two other types of service companies became more prominent: third-party administrators, TPAs, and firms offering administrative services only, ASO contracts. TPAs and those insurance or companies providing ASOs contract take on the administrative responsibility of handling claims for funded groups. To handle an unexpected rise in healthcare costs or a number of catastrophic or chronic claims, self-insured employees often invest in excess or surplus lines of insurance, such as reinsurance or stop-loss coverage. Specific top-loss protection becomes activated when an individual claims reach the deductible levels selected by the self-funding group. Minimum premium is another means of financing medical benefits. It's this method an employee pays a segment of the regular premium to insurer to administer the benefits program and provide specific and aggregated stop-loss insurance. The employer maintains a bank account to the insurance company taps for payments of claims. Regardless of the size of the company and its method of insuring and administering health benefits, it is the case manager's responsibility to know the allowances and restrictions of the benefit plan. In addition to the setup of the plan, the case manager needs to know the relationship of the referring party to the claimant. Along with claim payouts, many insurers, TPAs, and ASOs serve as broker administrators and provide a broad range of specialized or ancillary administrative services. Employers have to manage employees' growing sense of entitlement in conjunction with their disconnect regarding risk factors and the true cost of health care. Report cards were a direct response to employers' frustration with the burden of health care expenses. These tools compare health plan performance in key areas of accountability, such as quality, utilization, administrative responsiveness and performance, consumer satisfaction, and cost control, and help answer the questions: what are we getting for our money? A coalition of more than 134 public and private organizations providing healthcare benefits, the Leapfrog Group represents approximately 37 million healthcare consumers in 50 states. Payers want to know how successfully a case might be handled through case management prior to giving the go-ahead for its application. So current standards lump all cases together. Case managers have created a win-win scenario in which both parties and payers are well served. Case managers are providing services in working cases in many practice settings, but when they are employed directly by the employer group, hospital, or insurance company, case managers have a greater opportunity to review medical care and benefit dollar protection issues thoroughly, and to position case management within the organization and to its client groups as a solution to escalating healthcare costs. The next step in educating insurance providers and administrators is to convene them to put case managers in more pivotal positions and make them an integral part of the high-level management where they can report the true benefit of case management, expand case management services to multiple lines of insurance, and increase the value, marketability, and awareness of case management. The government has been a payer of health insurance for the elderly and economically disadvantaged for many years and has been in the forefront with some initiatives to contain cost. Cost control methods have focused efforts on acute care hospital utilization, doing little to address the issues of problems or individuals who could benefit from case management intervention. Most case managers today have some experience with public forms of insurance and occasionally are working within several lines of insurance on the same patient. To reduce costs by more effective intervention, government case management programs have typically looked at several of the following: high-risk pregnancy, high-risk newborn, sickle cell, AIDS, psychiatric, cancer, and drug and alcohol patients. There is room in public sector case management to do the right thing through use of alternatives to the generally accepted plan. The level of scrutiny of and accountability for case management services has increased significantly over the years. There is a great deal of oversight from the state and local government of any communication that goes out to the Medicare and Medicaid population, and all policies and procedures are thoroughly and stringently reviewed. Because Medicare and Medicaid is a risk to lose money because of unmanaged or poorly managed high-cost cases, just as private companies are, it has become the mandate for them to resolve the problems, inclusive of contract language exceptions or paying for benefits in lieu of greater exposure to the plan. Medicaid reimbursement is often considerably lower than what providers can obtain from private insurance. In traditional Medicare programs, the insured are typically over the age of 65, and although there certainly are exceptions, many of them have several medical conditions. Growing number of elderly watching their dollars due to lowered incomes, economies by reducing medication to 1 or 2 times a day or fewer times a week instead of 3 times a day make the drugs last longer. Another area of concern that we are seeing with growing frequency as our society ages is the condition of dementia and the related diagnosis of Alzheimer's and Parkinson. Often difficult to diagnose, these disorders truly complicate the management and safety of the individuals affected by them. There are many restrictions, exclusions, and limitations in Medicare and Medicaid. Most Alzheimer and dementia diagnosed patients need support services rather than skilled care services, which typically are not covered. Yet if patients do not take their medications and become malnourished and dehydrated, they most assuredly will develop a medically covered condition. Case managers are often able to serve as a broker of services by referring the frail elderly to community-based programs such as Meals on Wheels, Alzheimer's Day programs, and others. Perhaps the most difficult case for case managers active is in public sector programs or those we face when working with the underserved, economically disadvantaged individuals who are in the various state-funded Medicaid programs. Because economic needs is the major criteria used for Medicaid eligibility, it seems reasonable to accept that certain other factors will replace from its beneficiaries at risk. Those who are unemployed or underemployed may also have a need for food, housing, clothing, and transportation. Case managers working with these individuals will need to be especially skilled and experienced, not just clinically, but equally important. The practice setting of case managers in the military has grown rapidly in recent years. Because of improvement in body armor and advantages in care on the battlefield, there are many more survivors, but these individuals have far more severe injuries and disabilities. The military case manager has become an essential member of the multidisciplinary team that orchestrates care and services for wounded warriors. As part of the treaties dated back to 1921, there was a promise that the U.S. government would provide tribes with doctors and supplies. Indian Health Services was founded in 1955 and is the agency that fulfills the legal obligations within those treaties and legislation. In 1976, the United States enacted the Indian Health Improvement Act, which serves 564 federally recognized tribes. While the Patient Protection Affordable Care Act, the growth of case management has exceeded our hopes and expectations. We might be tempted, therefore, to think of ourselves, finally we made it. Our value is recognized, so now we can just take care of our patients. That would be, unfortunately, a very big mistake. As the healthcare industry strives to improve the efficiency, quality, and safety of care to its stakeholders, from policymakers to payers, there is an increased emphasis on quantifiable outcomes. Outcomes describe the results and consequences of care received. Outcomes can result from the care that was not received. Because case managers are in care coordinator roles, we need to be able to demonstrate that our intervention made a difference. For effective outcomes management in any given setting, 2 levels of analysis are necessary: monitoring outcomes at the point of care, which is microsystems, and at the organizational level, which is macrosystems. At the microsystem level, case managers have the proper skill set through their basic academic preparation, clinical experience, and continuing education to serve as the nexus for coordination of outcomes from admission through discharge and beyond, the various transition of care. Their role is to ensure that as the patient moves across the continuum, there are no serious lapses in their care. Case management at the macrosystem level is also important, and the same kinds of outcomes are monitored and reported, but with a focus on aggregated data for entire populations or programs. The majority of healthcare professionals today probably entered the field with the desire to help others. We were the actual hands-on providers of the services deemed necessary. Because of its role in cost containment, case managers focus on catastrophically ill patients and high-cost cases, as well as those predicted to be so, such as disease management cases. Discussion of fees and costs should be part of any case management program. Financial issues need to be examined and debated before a company implements such a program or contracts with case management provider, or before a professional decides to be a provider of case management services. There are several ways to obtain pricing information while learning about a company and its services. One of the easiest is to attend local, regional, national conferences. When the necessary cost information is acquired, what should be done with it? For the small company or independent practitioner, perhaps keeping a separate provider book will be sufficient. In larger organizations or case management departments, serious consideration should be given to putting such information in a computer database. The first thing to keep in mind in negotiating is that there are ranges in prices for everything in healthcare. This does not mean that we aim for the least expensive category, selecting a Rolls-Royce price to guarantee excellence. The goal is to try to fulfill patients' equipment and service needs in a cost-justified manner. Negotiating is a specific form of educational communication. Case managers employ various strategies in discussing with payers as opposed to providers. When negotiating with a provider such as home care agency, the case manager most often is one healthcare professional talking to another using similar terms supported by shared accountability. Negotiating with a payer for approval requires a different track and tact. The case manager is no longer the decision maker. Whether it is insurance carrier, self-funded employer, or third-party administrator, the healthcare dollar and ultimately the decisions are the payers. The payer may not have the medical knowledge or expertise to know what is the case manager seeks and why. If case managers encounter resistance, I would encourage them to go behind the no. It is becoming more likely for case managers to negotiate an out-of-contract benefit in the managed care environment. HMOs and PPOs are realizing that although they may have contract limits and established contract language, in some very high-cost cases, they may have to do more creative and unusual things. I believe it is important to document and communicate the terms of agreement that case managers arrange with providers. Documentation includes cost-benefit analysis summaries and quality assurance surveys. Various forms and provider agreement sheets are provided and explained later on. Cost-benefit analysis reports and quality assurance surveys need to be communicated appropriately. They should be provided on a regular basis and ideally are presented in personal meetings. Case managers are experts in assessing and resolving problem cases. Others cannot be expected to understand the case management process as well as what we do. It is not enough to manage the case. We need to manage our relationship with clients as well. Educating clients allows them to buy into case management and helps avoid mismanagement discussions.